Okay, picture this. It's 3 a.m. on labor and delivery. Your pager's practically vibrating off your scrubs. Your coffee went cold like 3 hours ago. And you are staring at the central monitor watching a uterine contraction pattern that literally looks like a mountain range. You can feel the burnout just creeping in as your brain automatically runs through the mental checklist to fix it. Look, we have all been there. But in this explainer, we are diving into some massive, seriously practiced shifting data that's going to completely validate your L&D fatigue while totally blowing up the way you view this common clinical headache. Get ready, because we are giving you a data-driven paradigm shift. Which brings us to the ultimate, absolutely exhausting tension of modern obstetrics. You're standing there, staring at that monitor, meticulously counting contractions, sweating bullets over the strip, and you kind of have to stop and ask yourself, wait, are we treating the tracing, or are we actually treating the baby? Honestly, so much of our practice is driven by the absolute terror of what a piece of digital paper is screaming at us. So today, we're cutting through the noise and looking at the actual medical evidence of who we're really helping. Let's ground this in reality. You know the 2009 Apgar dogma by heart, right? Uterine tachysystole is more than 5 contractions in 10 minutes, averaged over a 30-minute window. The literal second we see that, our knee-jerk clinical algorithms kick into total overdrive. We rush the room, we flip the patient, we dramatically smash stop on the Pitocin pump, we push a fluid bolus, and we are immediately reaching for the terbutaline. It is a massive, stressful cascade of interventions, all based on one totally rigid definition. But are those frantic, middle-of-the-night fire drills actually improving neonatal outcomes? We aren't just throwing around opinions here today, people. We brought the evidence-based receipts. Enter a massive 2026 systematic review and meta-analysis published in O&G Open by Dr. Fabrizio Zullo, Dr. Suneet Chauhan, and a powerhouse multi-center academic team. This isn't just some casual op-ed. This is a rigorous, PRISMA-compliant deep dive into the actual cold, hard data. And when I say a deep dive, I mean they looked at a jaw-dropping 68,412 parturients. Seriously, let that number sink in for a second. This isn't some tiny, underpowered pilot study from a community hospital that you can just brush off. By pooling data from 5 major observational studies, this team delivered a massive, clinically robust reality check on what actually happens to tens of thousands of laboring patients. So, just how common is this headache? Out of all those patients, a solid 10.9% experienced uterine tachysystole. That means roughly 1 in 10 of your laboring patients is going to trigger this diagnosis. It completely validates why you feel like you are fighting this exact battle on every single shift. Because you are. It's an incredibly common, high-stress scenario that triggers an absolute ton of clinical busy work. But here is the thing, and this is why it causes us so much anxiety. Your clinical intuition, it's actually half correct. When we look at the fetal heart rate tracings, they absolutely do look worse. 93% of patients with tachysystole had some type of deceleration compared to 84.3% in the unexposed group. And the biologic plausibility totally makes sense, right? More contractions squeeze the spiral arteries more often, potentially strangling placental perfusion. We see the decels, we panic, and we naturally assume the absolute worst. So let's follow that logic. If the monitor is constantly alarming, the tracing looks like total garbage, and the spiral arteries are getting compressed, then the babies must be tanking, right? NICU admissions must have gone through the roof. Well, brace yourself, because this is exactly where academic dogma meets a brick wall. Boom! Here is the ultimate plot twist of modern obstetrics. Despite those incredibly ugly, stressful tracings, there is zero statistically significant difference in actual clinically meaningful neonatal morbidity. An Apgar score below 7 at 5 minutes, it was 1.4% in the tachysystole group versus 0.8%. Not significant. An umbilical artery pH less than 7.10, which is our gold standard for pathological fetal acidemia, 1.6% versus 1.9%. Absolutely no statistical difference. The tracings look terrifying, but the babies were completely fine. And wait, it gets crazier. Let's rapid fire through the secondary outcomes because this is wild. You would totally think that more tachysystole and worse tracings would lead to way more primary C-sections, right? Nope. Non-significant difference. What about severe outcomes, like Apgar's less than 3 at 5 minutes? No difference. NICU admissions, virtually identical. Neonatal seizures, death, zero difference whatsoever. Whether that uterus contracted 5 times or 10 times, the tangible real-world outcomes for both the mother and the baby were practically indistinguishable. Let's distill this huge statistical disconnect into a super sharp, memorable clinical pearl you can actually use. The classic dogma that was drilled into all of our heads is that tachysystole directly equals fetal hypoxia. But the actual evidence from nearly 70,000 deliveries tells us something entirely different. The data says tachysystole is simply a process measure. Sure, it alters the look of the fetal heart rate tracing, but it is not this inevitable fast-track driver to bad neonatal outcomes. All right, putting on our brilliant senior attending hats for just a second, we do have to talk about the gray zones here. We can't just toss the entire rulebook out the window, and here is exactly why. The big evidence gap in this whole conversation is that there are 0 randomized control trials on this topic. Every single study in this meta-analysis was observational. That means, yes, we can clearly see the lack of association, but we can't definitively prove causality just yet. We don't have a trial where we just let half the patients contract endlessly without intervening to see what happens. And why don't we have an RCT? Well, honestly, because it would be a complete logistical nightmare, basically akin to coordinating a toddler's birthday party in the middle of a hurricane. The authors literally did the math on this. To properly power an RCT to show just a tiny 33% reduction in low Apgar scores using our standard interventions, you'd need to randomize 17,000 patients with tachysystole. And since it only happens in roughly 10% of labors, you would literally need to screen at least 170,000 laboring patients just to pull that study off. So until someone gets massive funding and an entire decade to do that, this incredibly robust meta-analysis is the absolute best guiding light we have. So what does this actually mean for you, practically speaking, on your very next shift? How does this make you a smarter, more empowered clinician? Here are your actionable takeaways. First, absolutely expect worse tracings, but take a deep breath. Do not necessarily expect worse babies. Second, critically reevaluate your automatic use of tocolytics. Ask yourself, are you giving terbutaline because the baby is actually crashing, or are you just doing it to make the tracing look a little prettier for the central monitor? Third, contextualize those category 2 and 3 strips. And finally, the golden rule of medicine. Always treat the patient, not the paper. Look, we are all practicing in an era of really intense burnout, and we are constantly reacting to alarms that honestly might just be noise. This data finally gives us permission to take a step back and think critically. If tachysystole fundamentally does not change the actual outcomes for the mother or the newborn, is it time we push to change our national management algorithms? It's a provocative question, for sure, and it is exactly why staying up to date on the evidence is just so absolutely crucial. If this explainer made you feel even a little more empowered and maybe a little less stressed about your next L&D shift, hit subscribe and keep learning with us. We'll keep breaking down the evidence so you can just keep focusing on what matters most, your patients.